Hello guys, welcome back. This is the continuation of the previous video, congenital heart disease. So in this video, I will describe the radiological manifestation of the congenital heart disease, that is the acyanotic and cyanotic form. So acyanotic is due to the left to right shunt or obstructive pathology, whereas the cyanotic is due to the right to left shunt. So to understand this video, first watch the previous video in which I have described the pathophysiology and mechanism of the acyanotic and cyanotic congenital heart disease, so that you can correlate the radiological finding and it will make you easy to understand the radiological finding of the congenital heart disease. So let's begin with the this is the summary of previous class, that is the acyanotic congenital heart disease is further divided into the shunt, that is the left to right shunt, and the obstructive. So shunt is the ventricular septal defect, atrial septal defect, and patent ductus arteriosus, whereas the in obstructive coarctation of aorta, aortic stenosis, and pulmonary stenosis. And in cyanotic congenital heart disease, that is the tetralogy of Fallot, transposition of great artery, anomalous pulmonary venous connection or return, Epstein anomaly. Let's begin with the VSD, which is the ventricular septal defect. So defect in the interventricular septum. So this is the left to right shunt. If defect is less than 25% of the aortic annulus, it is called the small. If it is more than 75% of diameter of aortic annulus, then it is called the large, and in between these two is called the medium. So if defect is small in size, then there is no radiological manifestation or manifestation in chest X-ray. So in this image we can see there is a defect in interventricular septum, and this is the color image showing the flow of blood from the left to right ventricle. This is the CT image showing defect in the interventricular septum, and this is the mixing of contrast from left to right ventricle. If defect is large, that is the more than 75%, then only radiological or chest X-ray manifestation can be seen, and it manifests as the enlarged size of the heart, that is the cardiomegaly. Then, and there is especially enlargement of the left atrium is seen. So left atria is enlarged, and this will lead to the pulmonary hypertension, pulmonary edema, and pleural effusion. So pulmonary hypertension and edema can lead to the prominent pulmonary vasculature marking. As we can see in this image, there is prominent pulmonary vasculature, cardiomegaly. Now let's know briefly about the left atrial enlargement. What happens in left atrial enlargement and how we know in X-ray, or how we identify in X-ray. So there are direct sign and the indirect sign of the left atrial enlargement. So first one is the double density sign, that is the enlargement of the left atrium is seen adjacent to the right atrial border, and this will cause the double density sign. Another one is the oblique measurement of distance from the midpoint of the left main bronchus to the maximum right border of the left atrium, and if this is more than 7 centimeter, then it is called the oblique measurement more than 7 centimeter, and this indicates the left atrial enlargement, and for this double density sign is required. Another one is the convex left atrial appendages. So we can see in this image, so this is the convex and it is called the third mogul sign. So normally this is not prominent in normal chest X-ray or without pulmonary hypertension or without enlargement of the left atrium. So if there is enlargement of the left atrium, there is this bulge is seen, and this is called the third mogul sign. So let's move to the indirect signs. So first one is the splaying of the carina with the increase of tracheal bifurcation angle or subcarinal angle. So to say the splaying, it should be more than 90 degree. So in this image we can see that this is the normal, where we can see that there is a angle less than 90 degree, whereas in the left atrial enlargement this angle is increased, as this is denoted by this yellow line. And another one is the superior displacement of the left main bronchus. So we can see that there is a superior movement. So in this we can see that there is a oblique course, whereas in enlarged left atrial we can see this course is slightly horizontal as compared to the normal side. So these are the left main bronchus. Now another one is the superior displacement of the left main bronchus in lateral view. So this is seen in the frontal view, and the next one is the lateral view. So in lateral view it cast as the working man sign. So normally it left and right main bronchus overlap one another. In left atrial enlargement there is superior displacement of the left main bronchus, and this will lead to the working man sign formation. Now another one is the posterior displacement of the barium filled esophagus. So this is seen in the lateral field, and this will lead to the posterior compression or displacement of the esophagus, and this is seen in the barium study. Or if there is nasogastric tube in the esophagus, then this will also show the posterior displacement of the nasogastric tube. So these are the signs to identify the left atrial enlargement, and this is mostly seen in the ventricular septal defect, and other causes are also there for the enlargement of the left atrium. Now next is the atrial septal defect. As we can see in this CT image, there is a defect in interatrial septum. So appearance depends on the size, presence or absence of the mitral incompetence and the age of the patient. So if defect size is small or there is no complication, then chest x-ray shows the normal findings. And if it is large, then pulmonary plethora is seen, which is manifested by the appearance of the pulmonary vessels in the peripheral one third. This is the region where normally pulmonary vessels not visualized, but in plethora pulmonary vessels can be seen in lateral one third, and there should be the associated with the cardiomegaly, and this is due to the right atrial and right ventricular dilatation. If patient develops pulmonary hypertension, then central vessel or pulmonary arteries enlarge in size, and peripheral artery shows the pruning or narrowing of the caliber. Now the patent ductus arteriosus. So normally within the intrauterine life, patent ductus arteriosus plays a role in the blood circulation, which communicates the pulmonary circulation with the systemic circulation, and oxygenated blood mixes deoxygenated blood, and this will lead to the circulation or survival of the fetus. But in later after birth 12 to 24 or maximum of 4 days it closes. So if it persists, then it is called the persistent ductus arteriosus. As we can see in this image, this is the persistent ductus arteriosus, and this is the sagittal image of a fetus. Now this is the chest radiograph, which shows the cardiomegaly, as we can see in this image, cardiomegaly and pulmonary edema, as we can see in the lung field. These are the streaky haziness, and there is also blunting of the bilateral costophrenic angle. So this blunting suggests the small amount of pleural effusion, and this streak haziness suggests the pulmonary edema, and this is the cardiomegaly. As we can see, this is the cardiomegaly in large size of the heart, and these all together forms the suggest the pulmonary venous congestion due to the PDA. Now the Eisenmenger syndrome. It is the example of the left to right shunt with cyanotic condition. So in this condition, what happens? The long standing left to right shunt leads to the reversal of shunting, and this manifests as the cardiomegaly, central pulmonary artery enlargement, bulging of the left atrial appendages, and pruning of the pulmonary arteries, that is the attenuation of the peripheral pulmonary artery due to the pulmonary hypertension. Now the obstructive acyanotic lesions. So these are the coarctation of aorta, aortic stenosis and pulmonary stenosis. Now the coarctation of aorta, that is the narrowing or stenosis of the aorta. So it manifests as the figure of 3 sign, as we can see here. So this is the abnormal contour of the aorta. As we can see in this image, we can see that there is a notching in the aorta. This is the CT sagittal image. Now another one is the rib notching, that is the inferior rib notching or Rosler sign. So don't confuse with the superior rib notching. So superior rib notching causes are the different, they are not associated with the coarctation of aorta, and this usually seen in the 4th to 8th rib or occasionally from the 3rd to 9th ribs. This is due to the secondary to dilatation of intercostal collateral vessels which form as a way to bypass the coarctation and supply the descending aorta. The dilated and tortuous vessels erode the inferior margin of the rib, and this will lead to the notching. So what happens? This is the erosion due to the dilated collateral vessels. And this is usually seen in the long standing cases, not in acute. So this is not usually visible in less than 5 years of age. And if it is bilateral notching, then coarctation must be distal to the origin of both subclavian arteries. And if it is unilateral, then it is distal to the brachiocephalic trunk and proximal to the subclavian artery. So notching also determines the or help to identify the location of the coarctation. Now the aortic stenosis. What happens in aortic stenosis? Chest X-ray shows the prominent right mediastinal border, as we can see in this image. This yellow denotes the prominent right mediastinal border that is occupied by the ascending aorta, and the descending aorta is unfolded but it is normal in size, that is denoted by this red line. Now the pulmonary stenosis. In this, there is prominence or dilatation of main pulmonary artery due to the post-stenotic dilatation. As we can see in this image, there is post-stenotic dilatation of the pulmonary artery, and we can see this dilatation. Ventricular hypertrophy is also associated, and if it is present, then heart will appear as the boot shape, which is the typical picture of the tetralogy of Fallot. And there is also potentially decreased peripheral pulmonary vascularity. So we can see that the enlarged size of the pulmonary artery, whereas the other peripheral vessels are within the normal limit, as well as the heart is also within the normal limit. Now the cyanotic congenital heart disease, that is the right to left shunt or mixing of the oxygenated and deoxygenated bloods. First one is the most common type is the tetralogy of Fallot, then transposition of great arteries, total anomalous pulmonary venous return, tricuspid atresia, and abstain anomaly. Now the tetralogy of Fallot, which is the most common type, and it has 4 components: VSD, ventricular septal defect, pulmonary stenosis, overriding of aorta, and right ventricular hypertrophy. So let's discuss one by one. So we can see here that the tetralogy of Fallot, which shows the boot-shaped heart due to the concavity in the pulmonary artery region due to the pulmonary stenosis, and right ventricular hypertrophy lead to the upward lift of the cardiac apex. So this will lead to the appearance of the boot-shaped heart, and it is associated with the pulmonary oligemia or decreased vascularity or flow within the pulmonary artery, and 25% of cases it is associated with the right-sided aortic artery. Now the TGA or transposition of great artery, where we have seen that the swapping of the aorta and the pulmonary artery. So what happens? Pulmonary artery arises from the left ventricle, whereas the aorta arises from the right ventricle. So there is overlapping of these great vessels lead to the narrowing of the superior mediastinum and globular or ovoid shape heart appearance. As we can see in this image, there is globular appearance of heart. This is the globular appearance of heart and narrow superior mediastinum, and this will lead to the appearance of the egg on string sign. So this is called the egg on string sign, and this is specific for the transposition of great artery. In supracardiac type of total anomalous pulmonary venous return, it shows the typical finding of the snowman appearance or figure of 8 or cottage lobe heart sign. So what we see in this, there is the vertical vein, superior vena cava, and right atrium. So dilated vertical vein occupies the left side and drain over the brachiocephalic vein on top, and the superior vena cava on right form the head of the snowman, and body of the snowman is formed by the enlarged right atrium. Head is formed by this dilated superior vena cava and the vertical vein on left side, and the body is formed by the right atrium. So this is the snowman appearance or cottage loaf heart or figure 8 sign of the total anomalous pulmonary venous return. And this is only seen in the supracardiac variant, not in other. There is another very important sign, that is the scimitar sign, which is seen in the partial anomalous pulmonary venous return, which is essentially associated with the pulmonary hypoplasia, and it is almost exclusively seen on right side. So we can see here there is a scimitar sign or scimitar like appearance in the right lower zone due to the anomalous pulmonary vein draining into the inferior vena cava. And in chest x-ray it appears as a abnormal band like opacity in the right lower zone, as I have said in this image we can see. And this is the CT image. This shows the anomalous vein draining into the inferior vena cava, and this is the scimitar sign. Now the Epstein anomaly, in which malformed tricuspid valve is displaced downwards, leading to the enlargement of the right atrium. So in this chest X-ray frontal view or PA view, we can see that there is a globular enlarged size of the heart. We can see here, and this will give the appearance of a box shape. So this is called the Epstein anomaly or box shaped heart in frontal radiograph. Now these are my references, and thank you for watching.